Good morning, everybody. And before I start, I just want to say a great big thank you to Laura and Vanessa for all of their work in organising this and bringing it all together. It is incredibly difficult to follow Dr. Brown as a second speaker because she speaks with such passion, has been such a tireless advocate for how we progress. And I suppose she's also set the scene very well for part of what this discussion and why we developed this program. And it's really to kind of break through and explain some of the things such as APOE, ARIA, what it is, so that we're all better informed, be it researchers or be it people who are working in the area. So what I'm going to do is kind of set the scene for some of the day on just talking about the terminology that we use when we're talking about memory, and then talk a little bit about some of those recent developments about how we diagnose it and some of the excitement about some of the treatments and whether or not where the justification lies for that. So to start off, dementia is not a diagnosis. It's a term that we use that describes where as a result of a memory or thinking difficulty, somebody's not able to do their day-to-day function as well as they before. It's akin to saying somebody is short of breath. It is incomplete. And I suppose the objective of myself and other clinicians is to try and find out what is underlying it and what is it that's causing it. Why is dementia as a term important? Well, as an umbrella term, we're able to measure and see how many people are living with dementia. We know there's about 65,000 people living with dementia in Ireland. There's probably another 150,000 people who have what we call mild cognitive impairment, which is probably a risk state for at least half of them that they may go on to develop dementia. And the real key thing is we know there's this relationship between aging and dementia. So about 1 in 20 people at the age of 65 will have dementia. That increases to about 1 in 5 people by the age of 80, and it goes up to nearly 1 in 2 people by the age of 90. So the longer we live, the greater the risk. But lots of people age and die without developing dementia, so it's not equivocal with aging. We know about 1 in 3, from about 2015 onwards, about 1 in 3 people born in the UK are at risk of developing dementia. And I kind of always like bringing up this, it's from a year or two ago in the Irish India, whereby a baby born in Ireland in that year will have a life expectancy of 105 years. So things are shifting. So as much as we talk about today, as much as we talk about how we get therapies to help people today, we also have this other emerging issue whereby we have this aging demography, and it's about trying to narrow this gap between what we call lifespan, that it's the length of time that we're living, I'll bear that in mind, and if you like, the length of time we're healthy, health span. And when we look at dementia as a diagnosis, and this is why it's useful to look at this umbrella term, it's the common thread between many of what we call our gerontological syndromes, or things that happen to us as we age, such as the risk of developing incontinence, the risk of developing frailty, which is when we become more likely to get infections, risk of falling, delirium, which is where we get an acute confusional stage if we get unwell. And if we look at those conditions, which are often the conditions most linked to poor health as we age, or most linked to an increased risk of going into a nursing home as we age, or not being able to manage our own care at home ourselves, dementia is the common thread. It's one of those unifying factors. So when we talk about therapies, and I'll come back to this, for dementia, we've also got to remember these are possibly anything that can intervene in the progression of dementia is probably one of the biggest interventions we will have for all of these other things because it's such a dominant factor in the development of it. The most common question I get asked in clinic is what's the difference between Alzheimer's disease and dementia? And as I said, dementia really isn't a diagnosis. Alzheimer's disease is a very specific diagnosis that is related to the buildup of particular types of protein in the brain. But there's other causes of dementia. Alzheimer's disease accounts for 70% or so of dementia that occurs in people over the age of 65 and about 50% of dementia that occurs in people under the age of 65. Another important group and another important factor to think that although dementia is associated with aging, we know that there is a high proportion, about 10% of people living with dementia are under the age of 65. So it does affect younger people. With stroke or blood vessel disease within the brain can cause dementia. Parkinson's related, and Professor Kennelly is going to talk about Lewy body dementia, but Parkinson's related dementia, such as Lewy body, also can cause memory and functional difficulties. I think called frontotemporal dementia, which is caused by other proteins. And there's many other unusual causes, at least 25 or so other causes that are far rarer, but those are the main ones. And the key thing over the last few years is we've identified that the accumulation of toxic proteins in the brain, and specific toxic proteins, to each condition are associated with the development of symptoms. So for Alzheimer's disease, we know it's amyloid tau protein, and I agree with Helen, as I said, it's not all amyloid. There's loads of other factors going on in all of these dementias, apart from the one primary proteins. But we know for Lewy body, it's probably a protein called alpha-synuclein. For the frontotemporal dementia, it's probably several proteins, but in particular one called tau and one called TDP43 and other kinds of. So for different causes of dementia, we know that there's very particular proteins that accumulate within the brain, and of course that's really important. Because as we've seen with Alzheimer's disease, when you identify, and as we saw with COVID, and as we see with it, when you identify a target, science can get energized around trying to find therapies to remove it. And that's what a lot of the progress has been over the last 2 or 3 decades in this area. It's not just that we get typical protein associated, so it's not just that we get amyloid and tau associated with Alzheimer's disease, but we know those proteins tend to accumulate in certain areas of the brain first. So in Alzheimer's disease, it's typically in what we call the temporal lobes and the parietal lobes, where that protein will develop. In frontotemporal dementia, it's often the tau or TDP43 will be in the frontal lobe or the temporal lobe. And for the proteins that we see for alpha-synuclein that we see in Parkinson's disease, we can see a variety of areas of the brain that can be affected by that protein in the initial accumulation. So when I'm talking to somebody in clinic and I'm trying to establish what might be their diagnosis, that's why we always, and people are sometimes puzzled, because they come in telling me and they want to tell me about their symptoms right now, and they kind of seem a bit puzzled as to why I keep on going back to what were the symptoms 2 years ago, what were the symptoms? And it's because we know that the symptoms will relate to the part of the brain that was affected, and by knowing the part of the brain that's affected, we're probably narrowing down what type of protein might have been causing the issue. There is variation in this, and in particular we see in Alzheimer's disease, there's variation in this. So typically it affects the temporal lobe and the parietal lobe, and you can have short-term memory symptoms as your initial symptoms, but sometimes it'll build up in the occipital lobe, which is our visual center at the back of the brain. And as a result, people will present with visual, unusual visual symptoms that they're going to find hard to explain. Or sometimes that protein might build up in the frontal lobe and then present with behavioral changes. It's still the Alzheimer's protein, will be able to detect it's Alzheimer's disease, but for some reason, some people will accumulate the protein in a different area. And that's what we're always trying to tease out in clinic. I sometimes reductively refer to the brain as though it's like a fuse board. And the reason why that is that depending on the part of the brain that's affected, that's what your symptoms are going to, your earlier symptoms are probably going to reflect that most affected part. So it's the frontal lobe that's affected, we'll probably see behavior and personality changes. If it's the temporal lobe, oftentimes we might see some language changes, or we might see memory changes. If it's the occipital lobe, we'll see some visual changes. So depending on what part of the brain is affected, is likely to see changes reflected to impairment in that area. What's also though reassuring about the fuse board analogy is that while the sockets in the kitchen might be affected, the lights in the kitchen work, the sockets everywhere else in the house work. So actually, sometimes these presentations can be with very focal symptoms, and it's not a case where, as a result of a diagnosis of dementia, that somebody doesn't have retained all of an extensive range of capacity to do all those other functions. And that's what we really try and emphasize. That's what the work of the Alzheimer's Society is trying to emphasize, is that we find that means to support people to live well with dementia, that they're, that we really kind of, first of all, work on where there may be challenges, but then also try to find an infrastructure and a platform whereby people can also, really use those skills that they still have, that are of massive importance for them to engage in society. So what is it we're looking at in clinic? Well, I always often refer to dementia as it's a condition of altered perception. It's the one condition where two people can have completely different opinions and both be absolutely correct. Okay, because how we see the room, and there's often two different views of the room and what's going on. In clinic, we often talk about, well, what's the different types of memories that are affected? So we talk about short-term memory, long-term memory. We talk about things like, the intrinsic memories that we have, like our procedural ability, how we ride a bike, how we drive a car, how we brush our teeth, get dressed. Those are things that we do often procedurally, automatically, But then we'll also look at things like what we call declarative memory, episodes that we remember from life, or general knowledge memory. So actually memory isn't just, even though we use this kind of one word memory, it's a very complicated thing, and it goes out beyond that. We look for atypical symptoms. So we're trying to help people understand why their depth perception has become altered all of a sudden, why they have a difficulty moving between one floor pattern room in a room to the next room, which might have a different one, why they can't see two things at once. We look at praxis, how they've lost some of those automatic functions, language issues, whether it's generating words that's become the issue, whether it's understanding words that's become the issue, whether it's word finding difficulty, they know the word but they can't get it out. We look at altered behaviors, whether it's that they become more agitated, whether it's that they're misinterpreting what should be a benign and friendly environment as a hostile environment, or vice versa, whether they're overfamiliar. We look at sleep, whether they're having unusual dreams or nighttime behaviors, and trying to understand that a little bit better. And then walking is also that big integrated function that we do, which utilizes a lot of different parts of the brain. So we look and see any changes in walking, any increased risk of fall. So actually, when we talk about memory, it involves a complete assessment of people's attention, their short-term memory, long-term memory, their language competence, their visual spatial abilities, what we call executive function, their ability to plan and strategize. And that's why we look at how, and this is our clinic at Tallaght, it now involves, the traditional memory clinic model was really, doctor, possibly nurse, and neuropsychologist. Now we're very fortunate to have specialists, speech and language therapists, occupational therapists, nutrition, social workers, and the full range and gamut of individuals that also support us when we're trying to make those diagnoses and make those diagnoses a bit more accurate. So when we look at then the new emergence, well, certainly Alzheimer's disease is probably the first, if you like, condition of dementia that causes dementia that we've probably made most progress with. But we also, which in its own right as the most common cause is noteworthy. We also have to, look at the fact that Alzheimer's disease is often what we call a co-pathology. So even though somebody may have Lewy body dementia, or they may have frontotemporal dementia, they'll often have Alzheimer's disease pathology alongside the brain. So the advances that we're seeing with Alzheimer's disease are also of relevance to other causes of dementia, and that they can exist as a co-pathology. But perhaps most importantly is the progress we've made over the last 3 decades with Alzheimer's disease gives us a really good paradigm or platform to start looking at those other causes of dementia and how we would approach those. So we can extrapolate from what's happened. The first thing was we got really good clarity over what some of the key culprits are. And I use that term, some of the key culprits, because we know there's lots of different factors. But certainly amyloid is one of those key culprits as a protein that accumulates within the brain, and it kicks off what we call a cascade. And it's a cascade which ultimately leads to the accumulation of toxic forms of tau protein, and that ultimately leads to brain cell death. And typically it will affect the temporal lobes, where we'll have short-term memory deficits as an initial presentation, but it can present with different things. The other factor to bear in mind, though, is as that process is ramping up within the brain, you get this localized inflammation. And there's no question that that inflammatory response, as we saw with COVID, it wasn't actually the infection that did most of the damage, it was the body's response to the infection that was ensuing that did the damage. And similarly within the brain, when we get this low-grade inflammation, it's the body's response to trying to fight off some of these protein accumulations that can cause some of the most significant damage. One of the probably most important things is that these traces of proteins, we can detect them almost 20 years before people develop symptoms. So if you can imagine that within a cancer paradigm, where you have a pre-malignant state that you can detect, potentially for therapy, a tumor 20 years ahead of it actually causing its pathological, it's real kind of disease impact. And so it gives us a very good window of opportunity. And, we've kind of, that whole evolution has dramatically changed how we diagnose Alzheimer's disease. And in particular, what we know is in the absence of these biomarkers, and it's happened, we've established this in research recently when we looked at PET studies, and we established it when we first came up with what we call CSF biomarkers that I'll talk about. About a third of cases we diagnose as Alzheimer's disease are incorrect. So when we just use our own clinical judgment and don't apply biomarkers, up to a third can be incorrect. So now we combine that rich history that we will get from individuals about the sequence of symptoms and what their symptoms are and the tests, along with the application of these biomarkers. And that's what gives us far more confidence in the diagnosis. I would say the most important biomarker, and biomarkers are, if you like, those biological or clinical identifiers that we collect when we're trying to make a diagnosis. The history is the most important one. We now have imaging looking at MRI scans where we can look at patterns of shrinkage on the brain, or PET scans where we can either look at blood flow changes in some PET scans, or we can look at actually the accumulations of these proteins in what we call amyloid PET scans. But perhaps the most useful one clinically right now is where we take a sample of fluid called a spinal tap or a cerebral spinal fluid, and we're able to measure these protein levels within the brain, and often within the clinic I work in, within 2 weeks we'll get a result back on the amyloid and tau levels that somebody will have, and it will give us a very clear indicator of how Alzheimer's disease pathology may be contributing to their symptoms. This is probably one of the biggest, as much as we're talking about the new therapies, perhaps the biggest step change in how we diagnose and hopefully how we'll be able to inform better care for people is how close we are to a blood test. Really, most of the validation has been completed, and some of the work would have been done in an Irish context here as well on blood tests now that are almost as accurate as the PET scans or as the CSF scans. And for a large number of people, we'll probably be able to accurately and biologically identify Alzheimer's disease in people with mild symptoms through simple blood tests. And I would anticipate within the next 12-18 months, there will be commercially and clinically validated platforms around where within memory services, we'll be able to do those tests to establish whether or not there is Alzheimer's disease pathology. Of course, that better diagnosis then sharpens the focus on whom it is may benefit from therapies and who may be at greatest risk of therapies. So exactly as Helen was saying, so it kind of gives us a good clarity as to how we triage people coming in, and of course it gives us an opportunity to identify people at earlier stages. So I've said 20 years we may have accumulation. It kind of redraws our understanding of Alzheimer's disease as a condition that was associated with significant functional decline. We're now looking at Alzheimer's disease within the context of people with minor functional impairment. And in the future, who knows, we may be looking at it within the context of people with no symptoms at all, but identifying the presence of those proteins. So we're kind of pushing back, as we did with cancer, where we started where somebody had a mass and had a big lump on their chest x-ray, and we pushed it back further into microscopic identification. And now then we've gone into receptor identification for different tumors. Well, similarly, what's happening with Alzheimer's disease and dementia is we're pushing it earlier and earlier to get more accurate diagnosis and people at lesser stages of symptoms. So there's lots of excitement about these therapies. Lecanemab and donanemab are probably the two therapies that are most relevant. As Helen said, the European Medicines Agency, when they made their verdict, are the only agency in the world to have declined approval for lecanemab, and they raised some concerns. And actually, the truth of these therapies is somewhere in the middle. And my own feeling is that it was disappointing that people don't have the opportunity for me to have a discussion with them in clinic about, because I see lots of people who would have been eligible for these therapies. I see lots and lots, far more people who wouldn't be eligible for these therapies. We estimate about 1 in 5 people who would have CSF biomarkers would be eligible, and probably only about 7 to 10% of people attending my memory service with Alzheimer's disease will be eligible on the basis of the restrictions for these. I completely agree with Helen that ApoE genotyping, which is the risk genotyping, will become standard. And the reason why it's important is, of course, that relationship with what we call ARIA, because sometimes amyloid builds up in blood vessels. And we give an anti-amyloid therapy, those blood vessels become leaky, we can get little bleeds, or we can get little swellings in the brain. So how we address those risk factors, but they're manageable. As a stroke physician I worked at, we saw thrombolysis and clot-busting medicine come through. And clinicians and hospitals manage those risks. We manage risks within, the MX treatments that came through. We manage risks with new chemotherapies. There was no difference, and there is no difference in these therapies. It's small numbers and it's a start. And my own opinion on it is that we do need to be able to, develop our diagnostic capabilities to identify whom are the people most likely to benefit and whom are the people most at risk, and how we manage that risk. And this is what we mean by disease modifying. It's about shifting up that cascade. You know, so as opposed to our current symptomatic treatments where we're really just able to try and manage some of the memory symptoms, it's about trying to prevent that accumulation of amyloid and clearing it from the brain. And what these medicines do is they train the immune system to remove that protein. I'm getting a sign to tell me to finish up, so I'm going to click through. The key thing is, and this is really important for what Helen was alluding to, is there is 127 agents that are in trials at the moment looking at Alzheimer's disease. Very few of them are looking at amyloid. Most of them are looking at other pathways. They're looking at tau, they're looking at inflammatory mechanisms, and other pathways that are in earlier stages. So it hasn't been that everybody has put their eggs in the amyloid basket. It's just kind of been that as that primary culprit, this has probably been the one that we've addressed first. But we are in a new era of how we look at modifying Alzheimer's disease as a condition, hopefully minimizing those sentences. As an intro to Dr. Proctor's talk, we have already had disease modification, brain health, better blood pressure control, and all of those things has modified the course. And you know, people are 40%, an 80-year-old is 40% less likely to develop Alzheimer's disease or dementia today than we were 40 years ago. We just have an awful lot more 80-year-olds, and that's why we're seeing the rate going up. Okay, but we've already had disease modification. We really need to emphasize that message about brain health. But over the next 5 years, I think we will see this progress whereby we have timely identification, people stratified on the basis of benefit and risk for these medicines or other new medicines, and hopefully an era whereby we have people continue to live well and manage and mitigate that risk as they go through. Because like I said, it's not just about having a better memory. It's about having lower risk of incontinence, a lower risk of falls, less frailty, far more likely that you're going to age and live well within your home and hopefully die well there. Okay, so thanks so much for